Okay, let's make a start. It's 1:30 GMT. Welcome, everybody. You're very welcome to today's webinar on childhood disability in Sub-Saharan Africa. It's been organized for you by the Sub-Saharan Congenital Anomaly Network, or SCAN, and it comes to you via the Global Health Network program of webinars. We've got a great lineup of speakers for you, as you can see on your screen, and there'll be time for your questions also. I'm Helen Dolk. I'm Professor of Epidemiology at Ulster University, UK, and my co-chair is Dr. Phyllis Kisa, who's paediatric surgeon at the Makerere College of Health Sciences in Kampala in Uganda. Both of us have been involved in the establishment of SCAN along with many others, and Phyllis will say a few words about SCAN in a moment. We'll focus today on childhood disability relating to congenital anomalies, but we're setting this within a general childhood disability context. The physical and mental impairments that come with congenital anomalies are there at birth due to environmental factors in early pregnancy as well as genetic factors. But what creates disability is, as the Convention on the Rights of Persons with Disabilities emphasizes, how these physical and mental impairments interact with and are accommodated and mitigated by the environment to which the child is born. This environment includes all aspects of the inclusion of children with disability into the life of the community, the attitude of the community towards child disability and absence of stigma, the provision of equipment and aids and access to activities and education and leisure and financial help for families. But the environment also includes the provision of medical and rehabilitation services. And we know that in Sub-Saharan Africa, many children with congenital anomalies, particularly in rural areas, experience late and inadequate access to surgery, which leads to much higher levels and worsening of physical impairment associated in turn with the higher potential for stigma and exclusion. So the talks will enlighten different aspects of that today. I'll hand over to Phyllis to introduce herself and SCAN, and then we'll get going with the talks.
Okay. All right, good afternoon, everyone, or good morning, good day, everyone. Thank you for joining us today, and I'm glad to be one of your hosts today. My name is Phyllis Kisa, as Helen has mentioned, and I'm a senior lecturer and pediatric surgeon at the Makerere University College for Health Sciences here in Uganda. And I've been involved with a SCAN group, which was established through a fund from the UK Research and Innovation Fund and MRC funding. And it's still in its infancy, and we're still in the, in the initial 2 to 3 years of it. It's a regional congenital anomaly network that was established to support congenital anomaly surveillance, prevention, diagnosis, and care to build capacity in the region. And so some of these activities that we do are all part of that activity. And like we said, we're still growing. Thank you. I'll hand it back to Helen.
Thank you very much. You see some housekeeping slides on your screens, just to remind you that the webinar is being recorded and will be available afterwards on the SCAN website. Use the chat feature if you like to introduce yourself. The question and answer feature at the bottom of your screen to ask questions, and hopefully we'll get round to those questions at the end of the talks. And your camera and microphone have been disabled. Okay, so I'm very pleased indeed and honoured to be able to introduce today to you Dr. Claudia Kappa. She's going to be talking on collecting data on children with disabilities in Sub-Saharan Africa using the UNICEF Washington module on child functioning. Claudia Kappa is Senior Advisor for Statistics and Monitoring and Chief of the Child Protection and Development Unit in the Data and Analytics section of the Division of Data Analytics, Planning and Monitoring of UNICEF. And in this capacity, she is the focal point for data collection, data analysis, and methodological work on early childhood development, children with disabilities, and child protection from violence, exploitation, and abuse. She's led the preparation of over 1,000 UNICEF data publications, including the flagship UNICEF report, Seen, Counted and Included, using data to shed light on the well-being of children with disabilities. She represents UNICEF in the Washington Group on Disability Statistics and has co-led the development of the Child Functioning module and the Inclusive Education module that she's going to talk about now. Thank you very much, Claudia. Go ahead.
Good morning, good afternoon, good evening, everyone. Many thanks, Helen and everybody, for the warm invitation and the possibility for me to share the work that we have done when it comes to the child functioning module. So to explain what the child functioning module is and what also the child functioning module is not, I just want to share with you a video that UNICEF produced to release the module a few years ago.
Children with and without disabilities from around the world. When I grow up, I want to be a pilot.
I want to become a medical doctor.
In the future, I want to be a gymnastics coach. I'd like to become a teacher.
Ambitions and abilities. Every child has them, and every child is entitled to equal opportunity to realize their full potential. So say the Convention on the Rights of the Child and the Convention on the Rights of Persons with Disabilities. But the hard truth is that millions of children with disabilities are deprived of opportunity. Children with disabilities are among the least likely to get an education, to be employed as adults, to start their own families, and they are among the most likely to live in poverty. Efforts to include these excluded children have been impeded by a shortage of sound data on the lives of children with disabilities and those who care for them.
Animation illustrates the following concepts.
In the 2030 Agenda for Sustainable Development, the world's governments call for reliable data that go beyond averages to ensure that no one is left behind. Solid data on which to act and with which to measure progress. Those data are now within reach. In the past, data collection efforts relied on stigmatizing labels and diagnoses. Over the past 5 years, UNICEF and the Washington Group on Disability Statistics have developed a new way of gathering information on child functioning and disability. Mothers or caregivers are asked questions that explore children's actual experiences and the difficulties that they encounter in performing daily activities. The questions can be incorporated into existing data collection efforts. They take into account the fact that children develop and learn at different speeds and that the experience of disability changes as children grow. And they address the need for nationally comparable and internationally harmonized data.
Images of data collection efforts.
Many have contributed to this work in the spirit of partnership, from national governments and statistical offices to disabled persons organizations, researchers, and families. The international community has a shared vision of a just and equitable world, a world in which every girl and boy enjoys the same rights and opportunities, a world where no child is left behind. Building that world will take many hands. But now, we have a key with which to unlock the knowledge that makes progress possible and societies inclusive. Let's use it.
List of acknowledgements, including individuals, groups, and organizations. Full list can be found at data.unicef.org.
So I hope you enjoyed the video. It's a simple way to explain the objective of this module. The purpose of this module was to with a short set of questions, identify children with functional difficulties in population-level data collection. And this is really critical to understand what the child functioning module is meant to provide, but also its limitations. The child functioning module is not designed to provide a diagnosis. It's not a diagnostic tool. This was never the intention. We wanted to develop a short set of questions that can be included in population-level data collection to provide data that can be obviously reliable, but not necessarily accurate at the individual child level. So they have to be taken within the context of large-scale household surveys where we have access to mothers or primary caregivers of children. What can mothers or primary caregivers of children can tell us about their children? They cannot necessarily provide a diagnosis. They can report about the difficulties that the child might have in performing some daily activities that the mother or primary caregiver is able to observe and report on. And obviously, these difficulties need to be indicative of underlying impairments, but also take into consideration the role of the environment, meaning the child's ability to access, for example, certain services or assistive devices. We really wanted something that can produce statistics that are comparable across countries and over time. And we wanted to mainstream disability statistics as part of the larger data collection systems. So we wanted, the ambition was and still remain, to have disability statistics produced by countries and national statistical offices at regular intervals, as they produce data on GDP, as they produce data, for example, on labor and employment. We wanted disability statistics to become part of ongoing data collection efforts. In the development of this module, we follow some guiding principle in light of the purpose that I just described. Questions are related to functional difficulties and are asked to mothers or primary caregivers of children. Sometimes, to help mother respond in a way that produce valid and reliable answers, we realized very early on that we needed for the mother to think about what is a typical behavior or ability to function and use a comparison group. Obviously, we did so and we tested whether this comparison with children of the same age in asking mothers about their own children was appropriate through dedicated cognitive and field testing. Disability is conceptualized in the child functioning module according to the International Classification of Functioning and also the definition of disability included in the Convention on the Rights of Persons with Disability. Disability is conceptualized as a continuum with response categories that reflect this continuum. In the past, over 800 surveys and censuses included questions on meant to identify children and adults with disabilities. But in the past, most of the response category were yes or no. The questions were simple. Is this person disabled? And the answers were yes or no. And we realized that these type of questions and this type of response categories were very problematic. It produced a number of different biases in the response, but also left the respondent feel unhappy about having to choose something that doesn't reflect a continuum. So we try to overcome the limitation of previous data collection effort and be consistent with seeing and portraying disability as a continuum. We realized very early on that we needed to be specific when it comes to the age of the child and develop questions that would be different for younger children as opposed to older children. Again, in consideration of feasibility issues and to make the questionnaire as short and as simple as possible for use in household survey, we had to make some drastic choices. We tested a set of questions from age 0 to age 17. And we realized that unfortunately, when it comes to children under the age of 2, questions addressed to mother and primary caregiver that would cover the entire spectrum of 0 to 23 months of children were not able to produce valid and reliable answers. Because as you know better than anyone else, in this age group, children are in constant process of development, and identifying a short set of questions that can be responded by mothers and primary caregivers of all levels of education and across a multitude of countries was not able to produce the results we wanted. So we ended up with 2 sets of questions, one for children aged 2 to 4 and another set for children 5 to 17. And in many cases, we had to drop questions that will really produce results that we couldn't stand behind. So we did extensive testing to come up with a set of questions. And to select the domains of functioning, we used International Classification of Functioning. And I want to take a moment to acknowledge the International Classification of Functioning and explain how the child functioning module relate to the ICF. So as you know, this is a schematic representation of the ICF, which at the core, at the center, has this concept of activities limitation that can also be called difficulty in functioning. This is where the child functioning module focus on asking about activity limitations that the children might have with respect to key domains of functioning. We are also developing other modules that focus more on participation restrictions, but for the child functioning module, we were really trying to cover activity limitation, which also result from the interaction between impairments and personal environmental factors. For the children aged 2 to 4, so for the under 5 module, we cover these 8 different domains: seeing, hearing, mobility, fine motor, comprehension and communication, controlling behavior, learning, and playing. And playing being obviously a complex type of domain, slightly different from the other ones that you see here. When it comes to children age 5 to 17, as you can see, the number of domains that are covered by the child functioning module and the questions in the child functioning module is larger, because as we know well, with children expanding their environments and interacting with different caregivers, they develop also more complex type of functioning, and we wanted to capture the difficulties in this larger set of domains. Also because for younger children, mothers might not be able to observe, for example, certain difficulties simply because the child is not exposed or at a young age able to perform certain tasks and activities. So in addition to the domains captured in the module for 2 to 4, we have in the module for 5 to 17 questions related to difficulty accepting change, difficulty in concentrating, in learning, difficulty in making friends, difficulty with self-care, and we also include questions about emotions, specifically anxiety and depression. Again, everything filtered through the observation and the reporting of mothers, and we spend a significant amount of time testing and validating the responses provided by mothers and primary caregivers. The process took 6 years. And it was a very intense process, which started with a review of different instruments that were available to collect population level data on children with disabilities. So again, not assessment tools meant to be used by specialists, not diagnostic tools, but population level instrument. And then we hosted a number of different consultations, bringing experts with very different profiles: national statistical offices, because they are the one implementing household survey, organizations of persons with disabilities, but also academics, pediatricians, representative of governments, particularly line ministries. We undertook testing and validation. Testing and validation was done through cognitive testing, through field testing, And in some cases, the type of validation, for example, included comparison of responses given by mothers or primary caregivers with responses provided by professionals for certain domains, or comparison of results of responses provided by mother primary caregivers and other adult respondents on the same child. And finally, validation through comparison of responses between the responses provided by mothers and primary caregivers and responses provided by children themselves when it comes to adolescents and certain domains covered by the child functioning module. Since the launch in 2016, the child functioning module has been used in over 60 surveys conducted in low and middle income countries. And this is as of this week. We have every week we receive information about the surveys that included the child functioning module. And as UNICEF, together with the Washington Group, we have provided technical assistance to the national statistical offices that have implemented the child functioning module in these surveys. Because the child functioning module can be integrated in multi-topic surveys, mostly demographic and health surveys, these provide opportunities to look at indicators of well-being for children, including many SDGs, and then disaggregate these impact or outcome level indicators by the disability status of the child. So, for example, the child functioning module has been integrated in the UNICEF-supported multiple indicator cluster surveys, which collect data on over 100 indicators of well-being for children. And when used in conjunction with the CFM, these indicators can be then disaggregated, which give us great insight into this concept of equalization of opportunities, which is the main concern when it comes to providing, creating inclusive societies. So we have more than 20 surveys expected to be completed in the next 3 years. So in addition to the 60 already done, 20 more at least expected to be completed in the next 3 years. And thanks to this dramatic increase in the availability of statistics on children with disabilities, we have been able to provide and develop global and regional estimates on the number and proportion of children with functional difficulties, which we consider as the proxy for children with disabilities in line with the convention. And in my next 2 minutes, final 2 minutes of my presentation, I wanted to share with you the results of this analysis that we have done so far of these data sets. We have used the data set through statistical methods to extrapolate global and regional estimate, as well as to look at disaggregation of SDGs and other relevant indicators for children with disabilities. We published this in 2021 in the report that was mentioned earlier, seen, counted, included. According to our estimates, around 1 in 10 children worldwide have a disabilities. And when we look specifically at the Sub-Saharan region, we can see that in the case of Eastern and Southern Africa, this proportion is also in line with the global average of around 10.4%. In the case of West and Central Africa, this is the regions of the world with the largest proportion of children with disabilities, currently at 14.9%. In terms of numbers, for Sub-Saharan Africa, this translates to 70 million children with disabilities. And again, these are distributed as follows: West and Central Africa, about 41.1 million, Eastern and Southern Africa, 28.9 million. These are survey data, so there is always a little bit of a range when it comes to this estimate, but clearly a significant portion of the total 240 million children with disability worldwide are actually children living in Sub-Saharan Africa. These are the countries in Sub-Saharan Africa for which we have prevalence data coming from nationally representative household surveys. And you can see that the range, the proportion of children with functional difficulties in this country range significantly from 27% in Central African Republic to 8% in Lesotho, with quite a variation. And you can see that when we look at the further disaggregation by age, we see that when it comes to children 5 to 17, the proportion of children with functional difficulties tends to be higher than for children age 2 to 4. Just again to focus on Central African Republic, 31% of all children age 5 to 17 have functional difficulties. When it comes to children age 2 to 4, the proportion is 15%. Now, most of the children have difficulties in the psychosocial domain. So this is the overall distribution of the 240 million children with disabilities in the world by type of the functional difficulty that are reported. In the case of the 2 to 4, difficulty in controlling the behavior was the most commonly reported type of functional difficulty, followed by difficulty in learning and in communication. And when it comes to children age 5 to 17, anxiety, depression, difficulty controlling the behavior, as well as difficulty accepting changes are, again, the most commonly found functional difficulties. So we look at 3 indicators. I'm going to share with you 3 indicators, 3 main indicators related to children well-being, starting with stunting and disaggregating the results when it comes to stunting for children with and without disabilities. These are the countries in Sub-Saharan Africa for which we have this data. And I just wanted to point at the fact that in half of the countries with data, children with functional difficulties are significantly more likely to be stunted compared to children without functional difficulties. And this is probably an underestimate of the gap, because we know that to measure stunting, we need anthropometric measurement. And in case of children with very severe forms of, for example, disabilities, these measurements unfortunately do not take place through the standard tools that are currently available. We also can disaggregate foundational numeracy and learning skills by children with and without disability, thanks to the child functioning module used in multi-topic surveys. And I just wanted to point at the extremely low level of children in Sub-Saharan African countries with data that demonstrate numeracy and reading skills. And this is done through a direct assessment of the child's ability to read and do some basic math. Overall, in the countries with data, the levels of children, the proportion of children who can demonstrate that they're actually learning in school is extremely low, as you can see, less than 10% in all these countries to the left-hand side of the slide. Well, in half of the country, children with functional difficulty are even less likely than children without to demonstrate these numeracy and reading skills. And to complete, I just wanted to finish with another slide that show the proportion of children in the Sub-Saharan countries with data that experience severe physical punishment by caregivers at home. And as you can see here, children with one or more functional difficulties, which are depicted in blue, are significantly more likely to receive severe physical punishment by caregivers in half of the countries with data, while in the other half, the difference are not statistically significant. So I'm going to stop here. I probably abused my time by a few minutes. I apologize for that, and I look forward to any questions that you might have. Thank you so much.
Thank you so much, Claudia, for a very enlightening talk. Thank you. There would be many questions to follow on, but we will have to move on. Perhaps we could take just one question from the question and answer. Is it to Sa that I guess relates to your slide on literacy and numeracy skills? Are there policies for disability inclusion, especially with regards to access to education and free movement? Is asked.
Absolutely, there are such policies. I am not a policy expert. I'm a mere statistician. There are others in UNICEF that have been working to support the development of policies related to disability inclusion. They're best placed than I am to answer this question. But on our website, which I'll include in the chat, I will indicate where you can find resources that explain the work that UNICEF has done to support governments in the design and implementation of inclusive policies.
Thank you very much. There are lots of questions we'd like to ask you. If we have time at the end, we'll get back to those, but I'll hand over to Phyllis to introduce our next speaker. Thank you again.
Thank you, Helen. Just also to remind the panelists, you could also type your answer directly into the Q&A. That way, some of them can be answered, even if we may not have to do that live. Our next presenter will be Dr. Dorothy Nachuala, who's a managing research scientist at the Institute for Health Metrics and Evaluation. She works in the neonatal and child health team with a primary focus on global burden of disease estimates for congenital birth defects. Welcome, Dr. Dorothy.
Thank you, Dr. Kisa. Can you all hear me? Can you confirm that?
Yes, we hear you.
Thank you so much. Thank you so much for inviting me to be a part of this panel. And as introduced, I work at IHME as a managing research scientist in the neonatal and child health team. And today I was asked to talk about disability in Sub-Saharan Africa, associated with congenital anomalies, with a view from the Global Burden of Disease Project, which is a study conducted by IHME. I'm going to briefly define, so in my talk today, I'm going to briefly define what the Global Burden of Disease study is and the measures of disability that we use in this study. Then I'll also talk about some current estimates of years lived with disability due to congenital anomalies, and that is a measure of disability. And then I'll give some concluding remarks. So what is the GBD study? The GBD study is a systematic scientific effort to quantify or measure magnitude of health loss associated with different diseases. And in the GBD, we actually assess or measure disability due to, we measure disability or loss of health in relation to birth defects for about 11 subtypes of birth defects. And those are listed in our table, and they correspond in the table here, corresponding to various, these are classified according to various ICD codes that the majority of you might be familiar with, but I'm happy to answer questions about what those might look like. And these categories or categories or larger categories can further be subdivided into other categories as need arises or as preferred. And in the GBD study, we measure disability using a measure called DALI. DALI is, just a second, I think I'm having some. Okay. In the GBD, the disability adjusted life years, or a DALI in short, is a measure used to quantify health loss. In other words, the DALI quantifies the difference between a theoretical optimum health state and what a child or an individual actually lives. Here I have an illustration of what a DALI might look like. So let's take an example of a human being or a person born with full health, and that person lives up to 35 years, and then they experience a sort of like chronic disease. And if it was like a congenital anomaly, that experience might be earlier on in life. But let's imagine one that is experienced at 35 years. That person will lose a little bit their healthy life, and that is what is measured in green. And that chronic illness or something related to it might actually cause a death for this person who was expected to live a life of 80 years to die early at 60. And that's the part that is represented in red, and that's what we refer to as the years of life lost due to a disease or an outcome. And for the purpose of this talk, we will focus more on the green part, where we measure the non-fatal part of a DALY. So these two combined together or sum together lead to the measure that I talked about earlier on, which is a DALY. And for this talk, I'm going to focus on the years lived with a disability, which is the measure for the non-fatal part of a DALY. So in its simplest terms, years of life lost due to disability, or YLDs, is a product of prevalence of a given disease, and the disability weights, which I'm also going to get into later on, that is associated with a certain condition or health state that is due to that disease. The disability weight then, therefore, are needed to clarify the health loss for the non-fatal part of the DALY. And these are usually assumed to be a % reduction in the perfect health, as I sort of demonstrated in the illustration I had on the previous slides. And the disability weights are usually assigned a value between 0, signifying perfect health, to 1, which is an equivalent of death. And so in this slide, I'm going to try to explain how disability weights are assigned for maybe a congenital anomaly. For every anomaly in the GBD study, we identify an associated sequela. This is the outcome of a disease, some of which Claudia talked about, like functioning of a child, intellectual functioning. And this is performed through literature reviews. And then if we take an example of neurotube defects, some of the outcomes or sequelae that are associated with neurotube defects are motor impairment, intellectual disability, and incontinence. And this is in the GBD. Then we do use available literature and mainly like literature studies, to assign a proportion of cases experiencing severities of certain states to each of the sequelae. So these are further classified into either severe, moderate, or mild, or other classifications as needed. And this is what we have here. And then these health states are then assigned a disability weights. And so the disability weights were estimated or calculated as a result of surveys, sort of similar to what the surveys that Claudia talked about. And then these surveys were conducted in the GBD study in 2010 and 2013. And there's a publication that I will link or put in the chat at the end of the talk. And they were derived as a result of surveys reaching out to common people and asking them how they would rank life of living with a certain disability and in certain severity, in levels of severity. And one key thing here is that intellectual disability can be a sequela for different outcomes in the GBD. It's a sequela for, let me go to the next slide, for congenital heart anomalies and Down syndrome. So the disability weights assigned to those health states by cause are not different. They are the same for all. But what varies is the distribution that we get from literature. And what I forgot to mention is that the sources of literature for these severity distributions are not very representative, because we don't have a lot of studies that are conducted in Africa, and most of them assume that what we see in in Europe or America, where the studies are coming from, is similar to what we will see in Africa or other regions where we may not have data. And so this table has a summary of some of the sequela or health tests that can be that are associated with the different anomalies that we study in the GPD. And I'm just gonna fly through it, and you can look at it whenever you want. And so the next part of the talk, I'm gonna show some estimates or current estimates. And these are not the most recent. This is for the GPD 2019 round, which is the round that is currently available to the public. But the next round, which we are referring to as GPD 2021, will be available soon. So feel free to go back in your free time to look at what this might look like for the most recent round when it's released. But we can see that congenital birth defects in this matrix are ranked number 5 in the top causes of disabilities or years of life lost due to disabilities in children under 5. And this has remained constant since 1990 and 2019. This is for the global picture, and in Africa alone, they are still at number 5. I think the only thing that changes in the top 5 is malaria, which is introduced in the rare diseases, and still showing that congenital birth defects are still among the leading causes of disability in Africa and both globally. And this is what the distribution of YLDs for children under 5 looks like. And again, it's sort of similar to what Claudia showed. We see higher YLDs in Central and West Africa. Maybe this could be due to lack of data in other parts of Africa, but yeah, compared to the rest of the regions, we do see higher YLDs in children under 5 in Central and West Africa. And this is what the distribution of YLDs still looks like by region. And right under here, or at the start, we do see higher YLDs for Africa compared to other regions of the World Health Organization. And the causes or the defects that are causing the highest disability are musculoskeletal anomalies, followed by congenital heart. This classification is called others, so a lot goes into it. I'm not going to give it so much weight. And that said, some of the key takeaways from this talk are that congenital anomalies remain some of the major causes of disability, both globally and in Sub-Saharan Africa. As far as assigning severity of the disabilities, we lack some data from Africa, and so this may not be the true picture of what we see in Africa, because we are postulating data from other regions for severity distributions. And we are happy to collaborate with other people in Africa that have data that can lead to us producing better estimates. And as I showed in the last slide, musculoskeletal and congenital birth defects have the highest YLDs. And one of the things, I am not an expert in, I'm not a doctor or a surgeon or someone who works in the health sector in providing surgeries for this, but one of the takeaways is that these are some of these can actually be corrected for earlier on in life, and this could help reduce the YLDs that are associated with this. And thank you. This is a study that talks more about how the disability weights were assigned or how the surveys were conducted, and I will put the link in the chat.
Thank you so much, Dr. Nachiwala. I do not see any questions directed to you, particularly on the chat, but I just wanted to comment that sometimes you'll see shorter YLDs in Sub-Saharan Africa because some of these correctable problems have complications that could lead to early death or morbidity. And so the child would be dead. And so they have less years they've lived with a problem. So those that have mild, let's say, disabilities attributed to the anomaly may live longer with a problem because either they cannot access the care, but also a good number of them may die because identification is late, and also surgical correction should be timely. And if those things don't happen, then you actually don't have the numbers to count. I don't know if there's any questions coming through. In the interest of time, I'll invite Helen back if she has any comments, and maybe to introduce the next speaker.
Thank you very much, and thank you, Dorothy, for your last presentation. We'll go on to the next presentation then by Samrawit Ababor, and she is a medical doctor who has, she's going to talk first of all on experience of disability among children with spina bifida in Ethiopia, research and reflections. She's a medical doctor with 3 years of experience in clinical work and in research, and is doing her master's in public health and epidemiology. She's currently working as an assistant research coordinator in the SALT project of the Haragi Health Research, a partnership between Haramaya University and the London School of Hygiene and Tropical Medicine, and is responsible for the follow-up of children with neural tube defects, mainly spina bifida. Thank you, Samrawit. Go ahead.
Hello, can you hear me?
Yes.
Okay. Thank you for having me to present this webinar. So I'm going to be presenting about experience of disability among children with spina bifida in Ethiopia. So I will start with a brief introduction about neural tube defects in general, and then I will go on with the disability of children with spina bifida and our practical experience in the hospital. So neural tube defects are a group of birth defects that emanate from failure of neural tube defects to close properly during fetal development. And this birth defects occur when the neural tube fails to completely close in the first 21 to 28 days after conception. And they're one of the most common forms of birth defects affecting fetus and newborns worldwide. So we have different types of neural tube defects, including anencephaly, spina bifida, encephalocele, craniorachias cases, and encephaly. From this, spina bifida and encephalocele are compatible with life. And when we see spina bifida, we have different types of spina bifida. So spina bifida occurs when there is an opening anywhere in the spine, and sometimes only the meninges that cover the spinal cord protrude through the defect, and we call that meningocele. If the spinal cord and the meninges and sometimes the nerves go through the protrusion, then that's myelomeningocele. And we have the milder form of spina bifida, which is spina bifida occulta. In such cases, we don't have a big gap that would cause a protrusion of the spinal cord or the meninges, but there will only be a gap, and that gap will be seen as tuft of hair or just a dark spot or just a skin dimple, and that's the milder form. So when we see the cause, neural tube defects occur because of a complex interaction that is intertwined between genetic, nutritional, and environmental factors. And folic acid, which is vitamin B9, is mainly required for the formation of neural tube in early pregnancy. And this folate deficiency and insufficiency is the most common preventable risk factor of neural tube defects. When we see the prevalence, there has been estimates of 2 cases per 1,000 births globally, and about 322,000 cases pregnancies are affected by neural tube defects. And when we see the systematic review and meta-analysis that show the prevalence of neural tube defect in Eastern Africa, it was estimated to be 33.3 per 10,000 live births, and the highest rate was seen in Ethiopia with 60 cases of neural tube defects per 10,000 live births. And the most recent hospital-based study in northern part of Ethiopia, which is Tigray, showed around 13.1 per 1,000 births in the area. So another hospital-based study, which was a retrospective study that's done in the eastern part where we are currently based, showed around 10.8 neurological defect cases per 1,000 live births. And this has also been supported with CHAMP study, which is Child Health and Mortality Prevention Surveillance that is being conducted in other parts of Africa as well. So according to that, mortality risk attributed to neurological defects was 10.4 per 1,000 live births. And when we see the overall data from campus, there were 296 birth defects attributed to diseases attributed to birth defects. And from those, 69 were due to neurological defects. And from all the campsites of this 69, 44 were found in Ethiopia, which is the eastern part. So you can see how high the burden is. However, currently we don't have a national surveillance system of congenital anomalies, and still our institutional delivery is still low. So we don't have a comprehensive picture of the prevalence of NPD currently. But the ministry is trying to have this national surveillance system by starting a technical working group. So we are on the way to have a surveillance system. So by then we'll have the true prevalence of the neurological defect in the country. So when we see the management, it's usually surgical correction of the defect and treatment of complications. So the complications can be hydrocephalus. So if the child has hydrocephalus, then there could be a ventriculoperitoneal shunt insertion, or if the child has clubfoot, then the clubfoot has to be treated. Or if the child has motor dysfunction or paralysis, then physiotherapy will be given. So when we see the prevention, Ethiopia is one of the countries with the greatest burden of micronutrients. So, and one of the micronutrients is folate. So having a high level of folate deficiency and insufficiency I think that it has been contributing to the significantly increased rate of neurological defect in the area. So with this high prevalence, we have seen the importance of large-scale mandatory food fortification with folic acid. And currently in the country, there is a mandatory wheat flour fortification. But since most of the people are from rural area and they don't use wheat flour, rather they use beef, and they usually grow their grains locally, it's really difficult to reach all the population. So currently the government is working in the self-fortification program so that many people can be reached. So when we come to disability of children with spina bifida, so it's spinal bifida is a multi-system problem that includes characteristic abnormalities within the CNS. So these challenges or the disability that the children are going to face will depend on the type and the location of the defect. But usually these children are going to face muscle weakness, loss of feeling in the affected areas, bladder and bowel control problems, or they might have deformities like scoliosis, lordosis, spinal deformities, foot deformities like clubfoot, and difficulty with learning, attention, and memory, especially if the children have things that would affect the CNS, like character malformation or hydrocephalus. So, like I said, children that have hydrocephalus or character malformation will have developmental delays, learning disabilities, seizures, and fatal outcomes sometimes. And these children, those with character malformation, will have respiratory problems, they might have vocal cord problems, they might have swallowing problems. So these are all the challenges that they may face. And in addition to the disability that the children are facing, then there are going to be high medical care costs, lifelong disabilities, and finally it might lead to perinatal and child mortality, which we are trying to prevent and to reduce. As I've said, they will have orthopedic complications like spinal deformities, scoliosis, kyphosis, lordosis. They will have urinary tract infections because they will have urogenic bladder, and they will not have bladder or bowel control. Especially if the nerves are damaged, that would prevent the bladder from completely emptying. So the other thing is healthcare providers may address these problems by using tubes or catheters. They can do clean intermittent catheterization to treat these children. They might have medications like oxybutynin to prevent urine from leaking accidentally and keep the kidneys and bladder working. And these children might also face challenges in achieving autonomy, since these children are mostly going to be dependent on their families for basic needs like movement, going to toilet or going outside. They will not be playing outside like the other kids if they have mobility problems once, for instance. So they are going to be facing this problem. And problems might persist into adulthood, and difficulties regarding employment, starting a family, and these are going to be other issues. So in my experience, I have not seen children that have, I have only seen one person who have grown up to be a doctor, but the other kids, in the ones I'm following up, the mortality is very high even after doing surgery. So it's kind of difficult to see these children grow up. And the survival rate into adulthood is going to be associated with advances in medical treatment. So in due time, with advances in medical treatment and awareness creation in the community, I hope we will see children growing into adulthood. In the preparation for future life should start at an early age, and we need to have an intervention program to support these children and these people through each transition. So they are going to be infants, and they are going to transition to the childhood, then adolescence, then adulthood. So we need to help them, and we need to create an intervention system that would help them transition. And previous researchers have investigated several aspects of living with spina bifida, including self-management, self-concept, and relationships, whether it is in the family or peer relationships. Coming to our practical experience, so I'm currently working in the SALT project, which is spina bifida anencephaly in Ethiopia, and folate for prevention. Our primary aim is to determine the population-based prevalence in the disease area located in the eastern part of Ethiopia. In addition to that, we are following children born with neurological defects that's compatible with life, mainly spina bifida and encephalocele in the hospital. We're following them after surgery and throughout the aftercare of these children. The other part of the SALT project is we're also going to see the folate deficiency and insufficiency in reproductive age women in the disease. In the other part is we're going to do a qualitative study to see if the population are going to accept the fortified salt, because somehow there will be a color change. So that's what we're currently doing. So the project was started in June. So we have 56 cases so far, up to September 2023. And from this, 49 were spina bifida cases, and from this, 26 had concomitant hydrocephalus. And most of these children have urogenic bladder, and we are doing clean intermittent catheterization for them. But the main difficulty with doing clean intermittent catheterization is that the mother, usually who is the primary caregiver, is going to do this clean intermittent catheterization, and that's going to be the mother is going to be trained by a trained nurse on this clean intermittent catheterization, but they are not usually willing to do it because we are introducing a new object to the child, and they are not willing to do it. So that's one problem. And the other problem is most of them have bilateral lower extremity paralysis, and they are going to need physiotherapy. But our setup is not well equipped for physiotherapy, and even for the small service we can provide, the parents cannot come to the hospital because they are usually from rural areas and faraway places. They can, because of economic constraints and because of some assumptions they have about this neurological defects, they are not going to come to the hospital for follow-up. So that's the main problem we're facing. And because of this, if the children are grow up to reach school age, the parents have to carry them to school, which is very difficult for the child as well as the caregiver, because the child will be in school. The children are not going to understand what's going on, so the child will not be able to control his. He will have bladder incontinence, so he's not walking like other children in the school. So that's creates a bit of a difficulty. And because these children they have some sort of functional disability, they are not going to school at the appropriate age. They have to, for example, they have to enter first grade when they are 7 years old. But these children are not going to school at that age. So that's also another difficulty. So when we concluded children are going to face physical or emotional and social challenges as they are growing or they're transitioning from infancy to early childhood and to adolescence. And the other problem is care for children is incomplete, as I said earlier. First thing, the parents are going to think that this is a curse from God or Allah, and they are refusing to bring the children to the hospital from the very beginning, because they assume it's a curse and they don't want us. They are going to fear the discrimination and the stigma from the community. They don't want to bring the child to the hospital. And for those who bring to the hospital, they believe that the first surgery is curative, and that's another difficulty. So when after surgery, we need a close follow-up of children for complications, because the complications are mostly going to be the main source of disability, like a child having bilateral paralysis will need physiotherapy. So he has to come 3 times a week to the hospital. So these things create difficulty for the parents. So for those parents who understand that they need follow-up and the first surgery is not curative, there's going to be many constraints, economic constraints, to bring the child to the hospital as frequent as it needs to be. So these are the main problems we have. And the outcome of surgery is poor because of poor follow-up of children, and children will develop hydrocephalus and infection. So the outcome of surgery is not as we expect it to be, and we're currently working on that. And children are going to require close follow-up and support in addition to surgery. The support needs to start in the family and then in the community, and the government has also to give emphasis on for children who have neurological defects or other congenital anomalies and who develop either physical or functional disability. And Ministry of Health as well as Ministry of Education need to give emphasis on how to help these children, and they have to conduct a research or a study to see the extent of the disability and what these children are going to need. And as I said, the aftercare is the essential part of treatment. Surgery usually is not curative. So this aftercare with physical therapy, wheelchair, braces, with plain term and catheterization is very important. And we have to have rehabilitation and behavioral interventions in the future to see what these children might need, and so that we can also give them psychological as well as social support. So thank you. If you have any questions, you are welcome.
Thank you very much indeed. your presentation showed the complexity of the problem of disability associated with spina bifida, and it looks as if your research will provide some of the data that's so scarce that Dorothy was referring to in terms of the data that's used by the Global Burden of Disease Project, for example, in measuring child disability. I don't think we've received questions. It takes a little while before people actually think of their questions, so we're a presentation behind each time. But if I could just ask you one thing, what do you think would be the major factors that could help school attendance and educational equality for the children with spina bifida in your area?
So I think the first thing is awareness, because first, the community doesn't have awareness about the cause of this problem, this neurological defect, and the government has not given it enough attention. So having awareness creation will be the basis of the trying to have equality for these children, equal services or education for these children. I don't know if I have answered your question.
Yes, I mean, I think awareness is a good first start for sure. Is there, could I ask Claudia to come in? Is there some way in which UNICEF is working on these problems specifically to work on equality and inclusion for children with disabilities, as Samrawit has referred to?
Absolutely. I mean, there is and plenty of activities. I'm not best placed to speak about that because my role is very narrow. I'm a statistician working with statistical office, trying to strengthen statistics. We have an army of people in UNICEF that work on policy advocacy across different sectors, for example, from education to health. So I want to do justice to knowledge and expertise, and I'm not well placed to describe the breadth of work that UNICEF is doing in this area. So if there are additional questions, maybe we can organize a follow-up discussion, more looking at program and policies for these specific Sub-Saharan region, and we'll be happy to put you in contact with those who can provide this overview.
That's great. Could I ask you a specific, sorry, Claudia, a question relating to what was just said about incontinence and toileting? That wasn't part, I think, of your child functioning module, was it? Something that was considered, or is it seen as belonging to one of the other categories?
So we have questions about feeding and dressing. So, and the difficulties in feeding and dressing, we tested bathing, we tested a few other questions, but with children, it was not really working well because, I mean, it's something that toileting and bathing, for example, we realized that children who have no difficulty functioning actually still require some help and support, and therefore mothers were reporting difficulties when in reality there weren't really. So we thought after cognitive testing that feeding and dressing performed well. We still found some difficulties in terms of mothers reporting false positive for very young children, 5 and 6. For example, that's why we don't use it for the under 5, but even with the 5 and 6 years old, still some false positive. So we acknowledge that, but again, population level estimates have some levels of errors anyway.
Thank you.
Go
ahead.
Okay, so I think what we have been doing so far is, doing research and collecting data and trying to show how much the burden of neurological defects. So by doing this, we are going to advocate for these children, and we are going to inform the government and the policymakers of the burden and the problems we are having, so that hopefully they will be able to integrate this, whether it is education or health or any activity that these children might require into the systems we already have.
Thank you very much. We need to move on, so I'll hand over to Phyllis Kisa.
Yes, in the interest of time, I just wanted to highlight that in the chat, Anita Carr has responded to a question that was raised earlier. And I think it also ties in with Dr. Samrawitz's talk about inclusion in schools and things like that. But I think in setups such as Sub-Saharan Africa, it's a bit complicated and complex because there's things like community nursing and have to be trained in some of these things or at school, and supplies for these children to be able to manage their bowels and bladder, because this is some of the things that makes it difficult for them to actually access school, because they smell of urine, they cannot control poop, and so their parents will keep them away. And the older they get, it even becomes harder. A 6-month-old baby in diapers who has spina bifida is not the same as a 14-year-old boy who has all the cognitive function, like in terms of physical makeup and how they can be looked after becomes harder and harder in a setup such as this one. But also to mention that some of the policies that are made, for example, a lot of these children, what actually kills them is urosepsis, wounds from infections, and some of these things, things that are easy to deal with if you know how to identify the children. But many times we don't focus on this type of children when we're making these things. I will quickly stop here and introduce us to the next speaker, who is Claire Bangirana. She's the Director of Research and Knowledge Development at the AfriChild Center in Uganda. AfriChild was set up to generate research that informs policy and practice to improve child well-being. Her research work focuses on strategies to prevent and respond to violence against children in different contexts, including humanitarian, street situations, residential care institutions, among others. She also has a vast experience in helping policymakers and practitioners use research and evidence in meaningful ways. She will be speaking to us today about violence against children with disabilities, a research done in Uganda. You're welcome, Claire.
Thank you very much. Please confirm that you can hear me.
Yes, we do.
Great. Thank you very much for the kind introduction. Thanks to the previous speakers, you've made my work really easy. I hope with my talk, which is going to be brief, I will be able to make the connection between the global the global picture that has been presented and what is happening in specific country context. So I'm going to share what is happening in Uganda based on a study we conducted between 2016 and 2018 alongside the National Violence Against Children survey, which typically doesn't go to residential care institutions or focus on children with disabilities. So I'll talk briefly about the country context, and then I'll go on to describe the nature of violence experienced by children with disabilities. I've mentioned this before on a similar platform with a SCAN network before, that we did not set out to explore violence against children with disabilities, but we came across this group as we were exploring experiences of violence against children in residential care institutions. So we came across this data and we decided to explore it a little more, and we have recently concluded another study looking at children with disabilities in refugee settings. So I'll be cross-referencing those two studies. In terms of the legal and policy framework, Uganda has made commitments by ratifying the UN Convention on the Rights of Persons with Disabilities. We see this commitment reflected further in the Constitution. We have a Persons with Disability Act. We have mention of persons with disability and children with disability in the National Development Plan, which is the broader framework within which planning and budgeting happens for our country. And specifically to children, our National Child Policy also acknowledges the difficulties of children with disabilities and mentions them as a special group. However, what is the picture? So we have the commitments made by government and actors on towards children and persons living with disabilities, but we also have what the current picture looks like. I think the previous speaker, one of the previous speakers mentioned that there is lack of data from Sub-Saharan Africa to contribute to the global statistics. So we see equally in Uganda that there is lack of data on disability, disaggregated data. We also see limited access to appropriate services, information, and resources, negative social attitudes, cultural myths. We have people who still believe that children born with mental disabilities are cursed, or they are ghosts, or the parent did something for that for them to have a child with disabilities. And this essentially means they're excluded from participating in socio-economic development of the country. So this talk, I hope, will be able to open a window into what happens when we don't address congenital anomalies early, leading to disability. And sometimes it's unnecessary. It's because of some of the reasons that people have mentioned previously in this talk, delayed identification and not being able to respond in time. So the broad question we're answering here is how these children understand and describe their experiences of violence. We were looking at 3 districts, Jinja, which has very many residential care institutions, and there were about 4 that had children with disabilities. And then we had 2 in Kampala, and a district called Mpigi with 1 government-run institution, which was initially intended for children that are in conflict with the law, but has since become a place where all children are taken, children that are picked up on the streets, including children with disabilities. Our methods included observation and field notes, because in one of the residential care institutions, most of the children had developmental disabilities, and for example, you couldn't interview them directly. So we had research assistants take notes. We had key informant interviews with probation and social welfare officers and other managers of these institutions and other people that work closely with the children. We had more body mapping interviews with children, those that were able to participate physically. We had reflective journaling. Some of the older children, boys and girls, were able to take notes for that period when we were collecting data on their experiences. So what this helps is there's no pressure for them to remember in the moment. So we gave them journals, and then they, over a period of about 3 to 4 weeks, they journaled every day about some of their experiences. And then we also conducted an extensive review of literature. That's one of the pictures from the data collection in one of the institutions, the children doing body mapping and describing the different types of violence that are experienced based on the different body parts. So our findings show that children are excluded in all processes, right from admission to these institutions. Again, the context is within residential care institutions, and we'll later see why this is happening. So even at admission, they are hesitant to recruit children with disabilities because of the burden it comes with. You have to take them to hospital, you have to, so they were hesitant. The other thing is that children are abandoned by their families and dropped off at dustbins, hospitals. So this is where some of these children are picked and taken to the residential care institutions. Sorry, I'm trying to move to the next, and my slides seem to have frozen. Okay, so I'll briefly describe some of the violence the children described. Most common was beating, slapping, and pinching. This was a qualitative study, so it's a slight shift from the measures of violence used in the global surveys, but it still resonates. So we had children reporting, this is in their own language. A staff member once beat a child to the extent of breaking their legs, and blood came out of the nose. And we have so many quotes by children describing the different experiences that they've gone through and seen their peers go through. When it came to emotional violence, we saw these are the people who are meant to take care of the children reminding them of their backgrounds and saying, that's why you are like that, that's why you are crippled, that's why, because you are stubborn, that's why your family is poor, or if you don't behave, we'll send you back to your home. They are labeled, they are abused, crippled, stupid, like children with developmental disabilities or mental disabilities are labeled stupid, and they are called stupid every day. They are discriminated against, they are segregated, they are denied privileges, or they are isolated because some would say they'll make the place dirty where all the other children will come. So they'll make the place dirty, they'll, and then they were subjected to extreme punishment causing fear. We also came across reports of sexual violence, defilement, sometimes by the caretakers or the people in these homes who are meant to be looking after the children. And the sad part with the sexual violence that occurs in that context is sometimes the children can't, of course, they cannot report. For example, children that are not able to talk cannot report, cannot describe what happened to them if it's sexual violence. So this is a quote from one of the social welfare officers, said, we have cases of pregnancy, but they don't leave the walls of institutions because they don't reach police. The institutions are able to shut this down before they leave the walls because it will damage the reputation of the institutions. And we had so many other, I would need to issue a trigger warning before sharing the quotes, but other descriptions of sexual violence, some girls getting pregnant and others being thrown out of the homes when they speak out regarding the violence, and then being neglected, living in unkempt areas. Some of the observational notes were like the dirty spaces, or children that cannot take themselves to the bathroom, sitting in pee and poop for long periods of time, or in the night staying in their pee all night, or being isolated, not being cared for because of what is considered the burden of caring for them. And then this is really why I mentioned earlier, we found that many of these children have parents that are alive and well, but because of the burden of caring for their children, they decide to institutionalize them, which increases their risk of experiencing violence, different types of violence. So a number of these children had their parents leaving and going on with their lives out there, and they are being subjected to all kinds of violence in the institutions. One of the boys said, I get worried that by the time I go back home, I might find that my family, my mother has shifted to a new place of residence. That was his worry. Another one says, I think by the time I go home, I might find all my parents dead, or I want to go back home. I enjoy home more than here. So it shows that they actually have homes and parents, but because of their disabilities, the parents choose to institutionalize them. And the homes we are talking about are orphanages. So the perpetrators were mostly within the institutional setting, were fellow children. Outside, they described violence being meted onto them by community members, cleaners, and other staff, caretakers as well. And this is also confirmed by our recent study that we conducted in refugee settings here, looking at children with, refugee children with developmental disabilities. A high number of them said they are being beaten. The community beats them, anyone beats them up, and they say, you are bringing a curse to this community. So the community is among community members are among key perpetrators of violence, and not to mention the parents themselves. It's in this context we are looking at institutions, so the parents were not there. That's why they're not mentioned here. But in this other study, parents are part of the perpetrators, and that also resonates with the national violence against children surveys that we've seen, the results that we've seen in Uganda, Kenya, Eswatini, and the other countries that have conducted those surveys. So in conclusion, we see that children with disabilities are at a higher risk of experiencing violence. discrimination in all settings and stigma. Experiences cut across all types of disabilities. It manifests differently with, for example, a child who can talk but has a physical disability might be able to describe what happened or speak to someone, but a child who can't talk won't be able to report or defend themselves or say anything about it. And our current child protection systems are not disability friendly or disability inclusive. So what does this mean in terms of policy, programming and research? We think that a multi-sectoral approach to addressing the needs of children with disabilities holistically would help, because if you address the health needs alone, these I've been describing are mostly social issues. The child might be healthy, but they'll experience, stigma and other issues. So being able to address all the aspects, including parenting skills, equipping parents with the skills to take care of their children, to be able to support their children, awareness and all that. So in terms of programming, we recommend strengthening the capacity of families and communities to protect children, especially the most vulnerable children with disabilities, because as we saw, the perpetrators are from the community. They are not strangers that come. They are people from the community that know these families, they know their homes, and then their own families, the parents. In terms of research, I am happy that at least UNICEF has made strides in guiding innovations on how we conduct research with children with disabilities, but we need to see more innovations on how we need to come up with more innovations on how we can do conduct research with children, so that even as we do research, we are not excluding them or their voices. And then lastly, more specific research into the patterns and risks of exposure, patterns of exposure to violence among children with disabilities. Like I said, depending on the type of disability they experience, or they experience violence differently. And so if we delved deeper into these patterns and the different contexts of violence, then we are able to come up with targeted and more effective interventions. I hope this has demonstrated or shown us a bit of what could happen or what happens when we don't take care to address congenital anomalies, to address birth defects earlier on, to prevent disability in the first place. So these are some of the experiences that children go through. Thank you very much.
Thank you, Claire, for your presentation. Yes, you're right. It's a very difficult subject to listen to. I don't see any questions for you directly on the Q&A, but I wanted to find out, what is your own experience with reporting these things to the police, for example? Because I know they have like a child protection unit, but working in the hospital, sometimes you see children where you suspect that there's been intentional injury to them, and there's no clear instrument of how we report this, but also there's the problem of where do they put them afterwards? And I mean, they might have to go back to that same family. I mean, do you know anything that you've experienced that might inform some of the things we do going forward?
Thank you. So the justice system has very stringent requirements in what makes a case that can be investigated. Even the evidence, as just a story is not enough for them to go ahead and, register a case. So there are challenges in there. It's already hard for children to go, and they need the child to say what happened. And many times, some of these children we've seen cannot say what happened. So there's really a need for awareness. The system is also not disability friendly. First of all, broadly, even children without disabilities experience challenges reporting and getting their cases heard because of the stringent conditions. You have to have done a medical exam, you have to have a report. Some of these you have to say pay for transport to go to a surgeon, to write a report for you to go to police. So the process itself is not friendly at all. There are some interventions, some organizations have put in place shelters as temporary places where children can go, or even women when they experience violence, where they can go, but those are not long-term. They are transitional spaces, and then try to identify another suitable place. But it's a challenge because eventually the child has to go back to their home, to their parents, and to the institution.
Yeah, it's very difficult. There's a question for you. I'm not sure, from Barbara in the Q&A. That is, the government of Uganda engaged in addressing the violence existing in the healthcare system? And what would you expect to be the role of government in, mitigating some of your observations?
Thank you very much. I think I'll start with what I expect the role of government to. So the government already made commitments, publicly made commitments to protect children, all children. We have all these very good and elaborate policies. So I would expect government to be deliberate in ensuring that even as we put in place services, they are holistic and they are, they cut across all the thematic areas, if it's health, if it's social protection, if it's education, to provide a holistic intervention, holistic protection, but most importantly, that they're inclusive, because we've seen their different manifestations. Their children also have different intersecting identities. They keep changing, so we need more holistic, more inclusive, deliberate actions around that, but also spearheading. I think we've gone past the time when it was assumed that people know what to do, people know how to parent. Some of the actions that can be taken include, when it comes to birth defects and congenital anomalies, it is other countries have passed laws to regarding fortification of cereal. There are certain actions that can be seemingly small actions, but can have lasting impact, preventing many children from getting into the disability bracket and thereby reducing the risks of some of this violence that we are talking about. So government can really do a lot. We've really made some strides. I know government has come up with parenting guidelines, and there's I think a draft national family policy, but we still have gaps when it comes to specific challenges like disability. It's still broad, and the assumption is that all children are the same. So we still need to be more intentional and deliberate. The other part of the question, sorry, I didn't write it down.
No, the other part of the question, oh God, I forget it and I've deleted it. Just give me a moment and I'll find it for you. And the second part is, what would you expect to be the role of the government in mitigating the current observations you've made?
I think I started with the second part. So the first part.
The first part is the government engaged in addressing the violence that you've seen in the healthcare system?
Yes, there are many interventions. For example, adopting and promoting 7 INSPIRE strategies to prevent violence against children. There is a shift towards, a focus on prevention, promoting prevention interventions, looking to scale interventions that have proved to be successful. There are structures that have been put in place specifically to respond to violence. At national level, there's an interministerial committee on child well-being. And this, the violence against children studies led to some of these changes. So we have that, and it's being replicated up to district level. So we see the intention is really there, but we still have a long way to go. I can't say that government is not doing anything. The intention is there. There are some shifts, but we still need to do more.
Yeah. I think some of what you've answers the next question that's for you, that how has AfriChild gone about breaking some of these prejudices that the community has around the causes of disability in children in Uganda, and I guess the violence as well, because we're running out of time. Do you have a quick answer to that response? How have you as a group?
As AfriChild. Interesting. We really disseminate our findings and then have community feedback sessions. So we go back to the community where this research was done and have the community interact with the findings. That's our approach as AfriChild, because we value the community input. We don't just take the research findings and go. So we've had several community feedback sessions. So it sort of loops back to the community and then upwards to the policy arena. Thank you.
All right, thank you so much. Before I invite Helen back, I just wanted to, I think there's a few other questions in the Q&A. Someone, Isatu, Sar, I think what you made is a comment and won't be responding to that. But also there's a question that any of the panelists can answer quickly from Felix. And he's asking, what is the universal activities plan for us in order to care about children? My sense, any of the panelists could answer this, but I think more of this is contextual, and in your own geographical locations, you have to identify what your problems might be and see how you can start intervening for them, because the problems are different in each of the countries, how society perceives these things, the infrastructure and the setup might be different to deal with it. And so there might be something that says, you know, SDG 3, and so you want to reduce all these things by a certain time, but that is the overarching thing, and the countries will sign up. But in the nitty-gritties of what you actually do, I think each of the geographical locations have to decide what those priorities might be and how they start to dig through them to be able to meet the SDG 3 at the end. I hope that answers Felix's question, unless Claire or Dorothy or Claudia Samrawit might want to add something to that before we can wind up. Anyone? Helen?
And perhaps, no, I was just going to say, if any of the speakers would like to make a final comment, I know we have to wrap up here, but Dorothy, would you like to make any final comments?
No, I just want to say thank you so much for inviting me, and I'd like to recognize the number of ladies from Uganda here. I'm so happy to connect with you ladies, and I'm originally from Uganda. And I'm happy to meet all of you. Thank you.
Great, thanks. And Samrawit.
Thank you so much as well. I have nothing more to add.
Good. And Claudia, I don't know whether she's still with us as we've gone over time. No.
I can see her.
Claire, yes.
So my last thoughts are, it coincides with where I'm at professionally. I am rethinking and reflecting on, for researchers, the access and privileges we have, the spaces we have, using our research as activism. Yeah, not to just inform, but as activism, because these children cannot come to these spaces. They cannot speak for themselves, but we can take their voices where they can't reach. So it's everyone's duty. And as a researcher, for a long time, I was not thinking of myself as part of advocacy of any agenda, but I'm currently reflecting on that and thinking we can all take what we do and use that as research activism, so that the voices are many. The activists are speaking, the parents or the people that are directly affected by disability are speaking, so that at the end of the day, we have a concerted effort towards improving the lives of children overall. Thank you.
Thank you. That's a very valuable comment to end on. And the SCAN network is developing its advocacy strategy along with research for similar reasons as you expressed there. I think we've had a good demonstration across all the talks of the biopsychosocial model of child disability and the huge complexity of the issue, and the need to really address that all together, and the value of speaking to each other across disciplinary boundaries in doing that. Phyllis, would you like to say the last word, and then we'll wrap up?
Well, I just like to thank our panelists, but also our listeners today. This is a heavy topic, and you've had the pleasure or opportunity to listen to all these great people speak to us. And what it does is, in no way do they try to give us the entirety of the information, but it's to kind of sow a seed in our minds about what we can do to make a difference in our little spaces, in trying to move the agenda of identifying these children early, knowing who they are, trying to access their care and supporting them, but also informing the community. Without all of us in the room, I don't think anyone can do their work. Dorothy mentioned that the data will always be skewed unless each of our researchers might create some information, then they can calculate DALYs and all these things. So each of us in our little spaces, we have a little something to do to, I think, feed into the bigger picture so that we can make a difference one step at a time. Thank you. Back to you, Helen.
Thank you very much, everybody. Thank you to all the participants, and thank you so much to the speakers for your fabulous talks. Thank you.
Thank you.
Until
Bye.
the next webinar.
All right.
Thank you. Bye.